Hi, Mike Gibson, Timothy Fairbairn here, and we're talking about the fish and chip study. Now, that has to be one of the more clever study names, Timothy. Talk to us a little bit about it. You looked at the outcomes in the NHS before and after the addition of FFR to CT and saw some improved outcomes. Talk to us about it.
Yeah, hi, Mike. And nice to meet you all. It certainly is a very British study name. What we were looking at is trying to assess the impact of adding in a FFR-CT or a CT-FFR program into routinely practiced healthcare in NHS England. So in England, we've been using CT coronary angiography as the first line diagnostic test for patients with suspected coronary artery disease or chest pain, really since about 2016 or 2017. And therefore, we've got an advantage over the rest of the world in terms of a bit of a longer use of this kind of pathway. And NHS England and NICE, which is sort of a quango body that recommend clinical practice in the UK, wanted to see the FFRCT used in clinical practice. NHS England actually said, right, we'll pay for it. We'll pay for the test to be used. We wanted to look at the impact that that had on a national basis on patient outcomes. So we looked at heart attacks, all-cause mortality, cardiovascular death, but also we wanted to look at how it impacted downstream tests, because one of the things that they felt that this technology could potentially do is reduce the unnecessary downstream tests. So we looked at all of these factors and really found some quite astounding findings following the implementation of the program at 25 different sites across NHS England. It did appear to improve or change patient outcomes in terms of all-cause death, vascular death. So really quite some fascinating revelations.
So you're just looking at anatomy with CT, but then you added the functional assessment with FFR, and you saw these changes in outcomes. So less use of, or I assume less use of some invasive procedures. Is that true, Timothy? Or more use?
Yeah, that's absolutely true. So what's important to remember, this is it's an observational multi-center study. So we were looking retrospectively to see what happened when this technology was made available to the different hospitals. So not every patient underwent the FFRCT, but we have over 90,000 patients. So it's a very much a big population data that we're using. Of that 90,000, approximately 7,800 went on to have a CT-FFR. But what we were really looking to do is say, well, look, if this is provided as a possibility as a second line test, so an add-on to that CT coronary angiography, does it make a difference in the overall patient populations? And because essentially of the large number of patients that we've got, we're able to answer that with sufficient power. And yes, it resulted in not just a significant reduction in the number of invasive tests. So that was a 5% reduction in invasive coronary angiography. That also resulted in a reduction in all downstream cardiovascular tests. So invasive caths, but also CT coronary angiogram, likelihood of having a repeat CT coronary angiogram within 2 years, and also reductions, particularly in the number of echocardiograms and nuclear tests performed. So yes, it did have the sort of the impact that was potentially stated in randomized trials, but in a real world environment.
So, Timothy, some people out there are going to say, hold on. You did fewer downstream tests, fewer caths, fewer PCIs, but mortality was reduced. Talk to us about what you think mediated that.
So it's always difficult to imply absolute cause and effect in a non-randomized trial. That's the first thing to say. But because of the size of the data that we've got, I think we can certainly go and look and try and get some greater understanding as the potential effects. So there are probably two potential reasons, and some of this we're still exploring with the data. The first is that we actually saw an increase in the number of PCIs, not overall revascularizations, but the number of PCIs by 8%. And that was significant only at the 2 year time point. So we looked at 90 days, 1 year, and 2 years. And there's a potential that may have some form of late benefit for patients. So they might have a slight increased risk initially when they're undergoing the PCI, but that could potentially over a longer term period have a benefit in terms of cardiovascular outcomes.
So that would
Interestingly,
suggest you reduce the number of false positives. The people going to cath really had the disease and had more interventions, but you didn't have a lot of false positives flowing through the cath lab.
yeah, essentially better patient selection.
Mhm.
We saw a reduction in invasive angiography. We saw an increase in the number of PCIs that occurred. So that what we call revascularization ratio, or some people call it cath lab efficiency, was improved. If that's a marker of the right patients getting and the right form of treatment, then certainly we did observe that. So that's one possible explanation. Um, the other really focuses around medications, and this part I'll be a little bit cautious because we're still looking at this data and analysing it. We've got over 15 million rows of data to analyse in terms of medications. And we're trying to look to see if there's any differences in medications. Now, most of the randomized trials or trial evidence in this is a comparison between a CT angiography test and a non-invasive test, whereby with all of our population, they all had a CT angiography test. So there shouldn't really be a difference in terms of the medications because they've had the same test and they've got very similar comorbidities. But that's something that we're looking at as well because it may be that there is a difference in medications which can explain.
Yeah, well, I mean, for me, I had a high calcium score, CT with FFR, and it did change my medical therapy. It was I didn't have an obstructive disease, but my medical therapy was escalated. So I could see how people would have intensification of their medical therapy. Are there any confounders here that might, have changed the results?
Well, there's lots of confounders. Certainly with the observational studies, as I've mentioned, there are many influencing factors. The first is that some of these observations, such as the reduction in invasive coronary angiography, you could argue were occurring anyway, because we know that a CT angiography goes up, invasive coronary angiography goes down, along with some of the downstream tests. But we've performed some complex analysis looking at patterns and trends, and we believe that all of the observations we're seeing are real, although the invasive coronary angiography pattern was probably going to occur anyway. So that was occurring in terms of the rate of reduction. However, there's a slight difference between whether you're just doing an invasive coronary angiography and not doing anything further, and an invasive coronary angiography and then going on and having a revascularization. And that was significantly different. So we're certainly still avoiding some unnecessary tests.
So can this be applied outside the NHS to people like me in the US?
So the NHS is a relatively unique healthcare system, but it's not that unique. I think there is some translation certainly within different healthcare systems. I've not mentioned about the costs, and cost is obviously an important factor as well. But something that we did try to make sure that we included lots of different settings and hospital bases. So we have a good geographical distribution. We've got a very good distribution in terms of different sexes. So we've got 48% females. We cover rural areas, inner city areas, big teaching hospitals, and much smaller hospitals. So I think there is going to be a good translation to different countries as well. But of course, the key question of this study was really to look at its impact within our own healthcare system, so we can say definitively that it has had an impact. I do think there will be some translation into different healthcare systems as well.
Well, Timmy, thanks for joining us. I think we all look forward to hearing what all of you are learning from Fish and Chips.
It's a pleasure. Nice to talk to you.